Hello everyone, good evening. So today I'm going to talk about a neonatal seizure or a neonate with seizure. It's a very important topic in neonatology. Now everybody know the meaning of neonate, isn't it? Neonate is the period first 4 weeks of life, or to be very precise, first 28 days of life. In neonatal period, the many problems can happen. Okay, one of the problems is seizure. The seizure is quite common in newborn period, and it is more common in preterm babies than the full-term baby. Look at the incidence there. In preterm baby, it can occur 60 out of 1000 live birth, and in term baby, it can just happen in 3 out of 1000 live birth. Why this seizure is very common in the newborn? That question must come in your mind, isn't it? And the reason is there is decreased seizure threshold in the newborn than in other age. Now, after we know this point, what is the pathophysiology of neonatal seizure? Why it is so common in them? What's the mechanism? Inside our brain, there must be the balance between inhibitory neurotransmitter and excitatory neurotransmitter. If there is an imbalance between them, in other words, if excitatory neurotransmitter has the upper hand than inhibitory neurotransmitter, there is very high chance of seizure activity. The same thing is explained there. The immature brain, or the brain in the neonatal life, has transient overexpression in the density of excitatory neurotransmitter, okay, like glutamate, and there is relative paucity of glutamate reuptake transporter. If both of these points we combine together, then it is very clear that there is excessive amount of glutamate, okay, in neurotransmitter junction, okay, or we can also call it synaptic junction. At the same time, the GABA channels or GABA ion channels are relatively underexpressed in the immature brain. So the activity of inhibitory neurotransmitter is already less. So only the excitation occurs. As a result of that, a seizure is very common. What are the etiology or causes of neonatal seizure? The common causes are shown there. Okay. Among all, the most common cause of neonatal seizure is cerebral hypoxia or ischemia. We can also use the term hypoxic ischemic encephalopathy or HIE for this aspect. Out of them, the global also known as perinatal asphyxia almost comprises of 40%, and focal infarction because of the focal ischemia in some part of the brain only comprise around 15%. Second common one is intracranial hemorrhage. Okay, this intracranial hemorrhage is mainly caused by vitamin K deficiency in the newborn. Sometimes it is simply because of birth trauma also. The third one may be central nervous system infection, okay, like meningitis, encephalitis, or brain abscess. So metabolic causes may also be there, okay, that may lead to transient metabolic disturbance, transient metabolic disturbance leading to transient seizure, or inborn error of metabolism lead to prolonged type of seizures. Another important cause may be cerebral dysgenesis. Okay, the cerebral dysgenesis is related to congenital anomaly of the brain. There is some abnormality in the brain development. And another very important group of etiologies are unknown. Different things can be combined there. This can be even more than 10%. Now there is one entity which is known as neonatal epileptic syndrome, and two important conditions comes under this heading. They are benign familial neonatal seizure and benign idiopathic neonatal seizure. Okay, they are benign conditions, means mainly they are not that lethal to the baby, and they may disappear on their own. Benign familial neonatal seizure is a autosomal dominant condition. Okay, it appears for 2 to 3 days and it resolves in few weeks duration, and usually the seizure is occurring during sleep, and lifetime susceptibility to seizure is increased in case of benign familial neonatal seizure. So it is slightly worrisome. Whereas benign idiopathic neonatal seizure occurs in around 5% of the term infant. It occurs at the age of 4 to 6 days, and this is a clonic in onset, or clonic type, I should say. The cause is unknown, that's why it is known as idiopathic, and it seldom lasts for more than 2 weeks. Okay, so just remember the terms here. What are the types of neonatal seizure? Now, the types of neonatal seizure could be subtle seizure, is the most common type. Subtle means very difficult to identify. Sometimes we are quite there, okay, in front of the baby, or very near to the baby, or we are examining the baby. Okay, seizure is happening in the baby, but we fail to identify it. Those types of seizures are known as subtle seizure. We should be very precise during the examination or observation. Clonic seizure, tonic seizure, and myoclonic seizure may be some other type. Now, what is the difference between clonic and tonic seizure? I'm sure students already know. Tonic means contraction, spasm. Okay, tonic, increased tone, and clonic means movement. If both occur, we call it tonic-clonic seizure, which is not common in the newborn. Okay, and myoclonic means sudden movement of the muscle group, jerky type of movement in the muscle group. Now, generalized tonic-clonic seizure, or GTCS, is extremely uncommon in the newborn because of the single fact that this brain in the newborn is immature brain. Okay, and this immature brain doesn't have good synaptic junction developed between the neurons. So if the abnormal electrical discharge originate from one area of the brain, that cannot propagate, okay, in a synchronized way everywhere in the entire brain. As a result of this point, GTCS, or generalized tonic-clonic seizure, is not common in the newborn. Then what type of seizures are common? Okay, they are called subtle seizure. They are quite common. And among those subtle seizure, okay, there may be ocular type of subtle seizure, okay, like some abnormal activity or movement in the eyes. Okay, there may be tonic movement of the eye. There may be nystagmoid movement, which is also known as nystagmus, the oscillatory movement, isn't it? Apparent fixation of the eye may also be there. That means the baby keep on looking at one area, or maybe in the space, just fixing the eye. Sometimes the baby may move the limbs like a pedaling. Okay, pedaling means just like we are moving our limbs during the cycling, isn't it? Similar type of movement. Sometimes even boxing, movement of the hands or upper limbs like a boxer, or sometimes swimming type of movement. So these are called subtle seizure. Sometimes there may just be autonomic change in the body. Okay, and those autonomic changes can be diagnosed by color of the skin. Okay, the color of the skin may go pale. Okay, or there may be a decreased capillary feeling. There may be tachycardia, there may be bradycardia, or there may be apnea. Okay, any of those may be there. So please never forget to examine the vital sign in the newborn if you suspect there may be seizure. One very important point regarding the subtle seizure is these seizures are not associated with EEG finding. Okay, electroencephalogram or EEG changes do not occur usually with subtle seizure. Sometimes the baby, okay, is not having seizure, but we may confuse that with seizure. So they are called seizure mimic. And the two important terms are highlighted there, that is jitteriness and non-nutritive shocking. Jitteriness, okay, is a faster type of rhythm or movement in the baby. For example, the baby may be hypoglycemic because of some other reason. And when I touch the baby during that state, the baby just shake the body, okay, sudden shaking of the body. This phenomena is known as jitteriness. It is not accompanied by any abnormal eye movement, okay, and it is spontaneous or stimulus sensitive. I just told you, and it may be stopped by passive flexion or repositioning of the affected body part. Whereas if it is a real or true seizure, it cannot be stopped by passive flexion or repositioning of the affected part. Okay, so this is a very important difference between jitteriness and seizure. Another is non-nutritive sucking, okay, just like sucking the thumb by some of the baby. And it may be confused with subtle seizure. So examine the vital sign. In non-nutritive sucking, usually there is no change in the vital sign, but if it is a real seizure, there is usual change. Now, how to confirm that this is a case of neonatal seizure? The first, diagnostic evaluation is always history taking or confirmation of the symptoms. Now let's talk step by step here. Regarding the onset of seizure, in which day the seizure has occurred, okay, there are some explanation here. If the seizure occurs in the first day of life, it may be pyridoxine dependent seizure. Now this is entirely a new term for you, pyridoxine dependent seizure. Now what is pyridoxine first? Of course, pyridoxine is vitamin B6. Now, pyridoxine dependent seizure. So how I understand this? To treat this seizure, we need to give pyridoxine, or in other words, the baby may be deficient in pyridoxine in this case. This is a type of genetic condition, okay, hereditary condition, and this is this runs in the family as autosomal recessive disorder. That's the first thing. The second one, it may occur in fetal life, even before the birth or inside the maternal womb, or after the birth within the first hour or first day of life. Okay, this is very important point. This seizure can only be stopped by giving vitamin B6. It cannot be stopped by giving other anticonvulsant drug. Okay, and these days some recent researches have confirmed that we should restrict lysine in the management of this type of seizure also. Lysine is a type of amino acid. Another cause of seizure in first day of life is post-asphyxial seizure. Okay? Post-asphyxial seizure is because of perinatal asphyxia or hypoxia at the time of birth. So this is a part of hypoxic ischemic encephalopathy. More than 50% of seizure occurring because of asphyxia occur within 12 hours of life. And these are very difficult seizure to control. Subdural hemorrhage can also result in seizure in the first day, and herpes simplex virus infection can also lead seizure in first day of life. In second day of life, hypoglycemic seizure are quite common. In third day of life, if seizure occur, we think of benign familial neonatal seizure, intraventricular hemorrhage, IVH, and some of the infection like toxoplasma, cytomegalovirus encephalitis. If it occurs from 4th or 6th day of life, we think of benign idiopathic neonatal seizure, and later on, after first week or even later, if seizure occurs, we think about intracranial infection, mainly meningitis. This is called late onset sepsis. Now, regarding the antenatal history, okay, some of the maternal condition has to be thought of, like fever with rashes. All the time we ask this question regarding the antenatal history taking. Who knows? The mother may be having herpes simplex virus infection during that time. Okay, maybe rubella infection during that time. Ask about maternal diabetes or gestational diabetes. The baby may suffer from hypoglycemia, and that hypoglycemia may be the cause of seizure. Any obstetrical problem, okay, should be asked. Both IUGR and preterm baby are at high risk for the development of seizure. IUGR or intrauterine growth retardation, okay, may lead to hypoglycemia, then seizure. And preterm babies usually develop seizure either because of hypoglycemia or hypocalcemia. And there is no need of any discussion. What are the causes of IUGR in preterm babies? And it's so many maternal or obstetrical conditions are responsible for that. Ask about, okay, some of the signs and symptoms of hypocalcemia or hypoparathyroidism. Now, hypoparathyroidism is under secretion of parathyroid hormone. Okay, and parathyroid hormone is so much necessary for the maintenance of calcium level. Ask about maternal drug addiction like heroin, methadone, or barbiturate. Okay, methadone and heroin, they are called opioid analgesics, and barbiturate, okay, like phenobarbital group of drugs. So if the mother, was taking this or addicted to this drug, then after the birth, okay, the baby may suffer from withdrawal symptom, and withdrawal seizure is quite common. Asks about history of previous fetal losses. Okay, detailed, obstetrical history is very much essential here. Who knows? The mother may be having TORCH group of infection, and that is responsible for multiple abortion or fetal losses. Regarding the intrapartum period, okay, or during the birth, asks about what type of labor is it? Is it premature labor or not, right? What is gestational age? If it occurs, before 37 completed weeks of gestation, we call it premature delivery or labor, and that newborn has a high chance of hypoglycemia, intraventricular hemorrhage, or intracranial hemorrhage, and hypocalcemia as well. All of these may cause seizure. Postterm baby may suffer from IUGR. It can lead to seizure because of hypoglycemia mainly. Maternal fever or sepsis at the time of birth can easily lead to meningitis in the baby, and maternal hypotension can cause asphyxia in the newborn. That asphyxia can result in fatal seizure. Asks about prolonged labor or antepartum hemorrhage. Prolonged labor and antepartum hemorrhage, mainly abruptio placentae, are important cause of perinatal asphyxia. Asks about whether the baby was suffering from fetal distress during the birth time or slightly before birth time or not. Okay, fetal distress is one of the indication of hypoxia in perinatal period. Now, perinatal asphyxia can itself cause seizure because of hypoxic damage to the brain, or it may be secondary to hypoglycemia, hypocalcemia, or even hyponatremia. So in one sentence, I can say perinatal asphyxia is one of the commonest cause of neonatal seizure. It is the commonest cause. After taking some good history, let's examine this newborn baby. Now, note the type of seizure in the beginning. What type of seizure is there? Is it subtle seizure? Is it focal seizure? Or is it generalized seizure? Remember, generalized seizure is not that common in the newborn. Examine the vital signs and find out whether there is tachycardia, bradycardia, or apnea. These quite commonly occur in case of seizure. Note the mental status of the baby, whether the baby is in coma, whether the baby is obtunded, or whether the baby is in stupor. Now, obtundation means drowsy state. Stupor means somewhere in the middle between drowsiness and coma. And coma, every student knows, isn't it? What is coma? Coma is a deep state of sleep from where, from where the patient cannot be aroused easily, even with painful stimuli. Okay, so baby, it is very difficult to arouse that baby by any type of stimuli. That is coma. Now, examine the eye. Okay, if you see cataract along with neonatal seizure, who knows, this may be a case of galactosemia. Now, galactosemia is a type of metabolic disorder where galactose cannot be converted into glucose. Now, this galactose will remain as a free galactose. And we have studied this in biochemistry. If some metabolic substance cannot go into normal metabolic pathway, it will divert into abnormal metabolic pathway. So galactose can form different abnormal substances, and those substances can badly damage other different organs in our body. Okay, in the neonatal life, it can damage brain as well as liver. Okay, this is called galactosemia. Chorioretinitis can occur in cytomegalovirus inclusion disease. So there are some findings in the eye. The face may be dysmorphic. This is called dysmorphism. Different syndromes are there. One of the commonest example I can give is Down syndrome. Examine the fontanelle in the baby. There are two fontanelles, anterior and posterior. Just gently palpate or feel the anterior fontanelle in the baby. But remember, when you examine the anterior fontanelle, the head of the baby should be slightly raised up from the bed. Examine the skin for neurocutaneous lesion. Okay, can you think of some example of neurocutaneous lesion? Absolutely. Cafe owlet spot is one of the example. Ash leaf spot is another example. Okay, port wine stain is another example. Now, in which condition these neurocutaneous lesion occur? Okay, you can write these different conditions here. Cafe owlet spot is seen in neurofibromatosis, especially type 1. Ash leaf spot may be seen in tuberous sclerosis, and port wine stain on the face usually is seen in Sturge-Weber syndrome. These are called neurocutaneous lesions. Now, if body odor is offensive, or some atypical type of body odor is coming from the body, then it may be a case of inborn error of metabolism. One of the common example I can give is phenylketonuria. Do detailed neurological examination in the newborn, okay, to find out hypotonic muscles, altered deep tendon reflexes, and if they are found, there may be badly damaged brain there. Okay. After doing history taking and physical examination, now it's a time for investigation. So what are the initial investigation in case of neonatal seizure? Look at the list. Blood glucose always comes as the first one. Any type of baby, if that baby is seizing or you Even if you consider or suspect seizure, do blood glucose immediately. Who knows, this may be a case of hypoglycemic seizure. Okay, always do this. Same calcium and magnesium level as well. Both hypocalcemia and hypomagnesemia can lead to seizure. Do CBC, okay, or complete blood count. What is the hemoglobin level? What is the total count, differential count? What is the platelet count? And send for blood culture and sensitivity test as well if you suspect infection is the cause. If you suspect meningitis, do lumbar puncture. Second line of investigation, apart from those which are listed, are neuroimaging like ultrasonography, CT scan of the head, and MRI. Okay, so these are always the second line after those first line investigation, which must be done. Investigation for metabolic disorder and congenital infection has to be done. Metabolic disorder, can you give me a few examples here? Okay, like phenylketonuria, like galactosemia, okay, like fructosemia. These are metabolic disorders. So proper investigation has to be done for them. And congenital infection means torch group of infection. So pretty simple. Okay, do the antibody for toxoplasma, rubella, cytomegalovirus, syphilis, like that. EEG may be useful for confirmation of suspected seizure and for the establishment of prognosis as well. Okay, towards the end of this topic, we'll talk about what is the prognostic significance of EEG. Now we are moving towards the last part of this topic, and that is treatment. Now, how neonatal seizures are treated? Just like any other seizure, we use anticonvulsant drug for the treatment of neonatal seizure. But one very big difference between the adult seizure and neonatal seizure is these neonatal seizures are less responsive to the conventional anticonvulsant. Okay, like what drug we used to give in the control of adult seizure, ongoing seizure? Diazepam or benzodiazepine. These diazepam or benzodiazepines are not commonly used in the treatment of neonatal seizure at all. We usually go for phenobarbital and phenytoin in this type of cases. Now, let's talk about acute management of neonatal seizure. That means if seizure is going on, how to stop that. Okay, first confirm whether this is a real seizure or not, and that can be easily done by examination. Another step may be check blood glucose level. Okay, if you suspect hypoxia, okay, check arterial blood gas, and if you suspect electrolyte abnormality is the cause of seizure, check serum electrolytes. If you believe the hypoxia is the cause of seizure, maintain adequate oxygenation, and even if seizure is occurring because of some other cause or reason, adequate oxygenation has to be established. Okay, because during seizure, hypoxic damage of the brain can happen. If the dextro sticks which you have done inside the ward, okay, or in the clinic is less than 45, that means hypoglycemia is there. So give dextrose or sugar, and your target blood sugar should be between 70 to 120 milligram per deciliter or even more than that. Okay. After giving dextrose as a bolus, you will give dextrose 10% by a continuous infusion. This is how a seizure because of hypoglycemia is managed. Now, let's talk about some other scenario or situation here. If seizure is not because of hypoglycemia, then I will try phenobarbital. Phenobarbital in 20 milligram per kilo over 10 to 15 minutes is given in the beginning. So this is also considered as a drug of choice in the treatment of neonatal seizure. If seizure continued even after 5 to 20 minutes of giving phenobarbital as a loading dose, okay, then additional maintenance dose of the phenobarbital has to be given. and that is 5 milligram per kg. Still, after giving phenobarbital, if the seizure persists, then we go for phenytoin or phosphenitoin. Okay, it is given at 20 milligram per kg intravenously and at the rate of 1 milligram per kg per minute. Do not give it very fast. If you believe hypocalcemia and hypomagnesemia are the cause of seizure, correct that. If you believe intracranial hemorrhage is the cause of seizure, okay, then exclude it by doing radio imaging test like ultrasonography, CT scan, or even MRI. If you believe metabolic, diseases are the cause, confirm it and then go for the treatment accordingly. Now, once seizures are under control, maintain the therapeutic serum phenobarbital level, and if central nervous system infection is suspected, send culture like blood culture or even CSF culture, okay, and then wait for the report, okay, then change the antibiotic according to the positive report, okay, but don't wait for the culture report to come. I will immediately start antibiotic, and then if a culture report shows a different sensitivity test than the antibiotic which you are using, then only change it. Now, regarding the poor outcome and good outcome of neonatal seizures, there are certain points. 50% of the hypoglycemic seizure have poor outcome because by the time we diagnose it, the brain is already severely damaged. In case of seizure because of intraventricular hemorrhage, 90% of them have poor outcome. So this is a very sad point here. We need to diagnose this condition quite early. Hypoxic ischemic encephalopathy, HIE, or also known as perinatal asphyxia, has 50% chance for poor outcome or another 50% chance for normal development. Meningitis, 50% have favorable outcome, 50% have poor outcome, and cerebral venous thrombosis, 20% of them may develop epilepsy in later life. Now, what is the good outcome point? Benign familial neonatal seizure, okay, only 10% will develop epilepsy. 90% of them, okay, will have a very good outcome. And benign idiopathic neonatal seizure, no epilepsy occurs later, so it has very good outcome. Now, what is the role of EEG regarding the prognostic value of neonatal seizure? Okay, there is better outcome if clinical and EEG seizures are consistently correlated. What does that mean? The baby is having visible seizure. Okay, you can easily identify this is a case of neonatal seizure. And at the same time, EEG is also showing some abnormality, then this has a better outcome. But worse outcome in case of EEG findings occur if this seizure is electrically silent. What does that mean? The clinical seizure is occurring, the seizure is going on, but EEG is not recording any activity. This is called electrically silent clinical seizure. Another important point, clinically silent EEG seizure. Now, EEG is showing abnormal activity, but clinically there is no visible seizure. So both of these conditions are showing poor outcome. If EEG seizure lasts for more than 30 minutes, this is the definition of status epilepticus. And if interictal EEG is abnormal, what does that mean? Interictal EEG means the state between two episodes of seizure. Even during the time, if EEG is showing some abnormal reading, then the outcome is worse. Okay, so at the end, please go through those questions and try to solve them confidently. Then only you realize that you have learned this topic well. Thank you so much.